Good afternoon. We'd like to welcome you to SAMHSA's webinar. This is part of Recovery to Practice series on clinical support. And our presentation today will be welcoming and culturally appropriate engagement for individuals with co-occurring mental health and substance use conditions. Our presenters today will be Dr. Ken Minkoff, Dr. Chris Gordon, and myself, Jackie Pettit. Our learning objectives today are, we have two learning objectives. The first one is to describe specific techniques and strategies for welcoming, engaging, and inspiring individuals with co-occurring conditions in psychopharmacologic practice, as well as in other treatment settings. Our second objective is to describe strategies to successfully engage individuals with co-occurring conditions where differences in culture, values, beliefs, and experiences exist between the individual and the provider. So now I'll hand it off to Dr. Minkoff.
Thank you very much, Jackie, for the introduction. It may seem odd that we're starting a series of webinars that have a focus on psychopharmacologic practice with a presentation on welcoming and engagement. But nonetheless, the success of being able to provide any kind of service to individuals with co-occurring mental health substance conditions, including psychopharm, involves creating an opportunity to develop the most successful relationship up front that you possibly can. In order to create an understanding of how that relationship is important, we wanted to begin by introducing the concept of how necessary it is to prioritize attention to people who have co-occurring mental health substance use issues and other complex needs. And we call this the complexity challenge. Individuals with co-occurring mental health and substance issues are folks who are prevalent everywhere in our service delivery system. They have issues not just in mental health and substance use, but in multiple domains, including health issues, legal issues, parenting issues, trauma issues, housing issues, and so on. They are folks who are associated with having the poorest outcomes in multiple domains and the highest costs, including people who are at highest risks of premature death. For all of these reasons, it would be important to think across our entire delivery system, wherever we encounter people who have co-occurring mental health and substance issues, that we would want them to be identified and engaged as a priority for care. So one of the starting places for how to be successful in working with these individuals is to think purposely. How do I as an individual, how does my program, my organization, make a deliberate effort to welcome these individuals exactly as they are into any service setting, including into a setting where the purpose is to prescribe medication. In addition to the challenge of welcoming people with complexity, what's also important right at the beginning is to remember that it's necessary for us to inspire people with hope. Hope is the driver that keeps people engaged when things get difficult. It's the energy that the people we work with bring into our conversations that allow them to do the hard work of engaging with us and doing things, including taking medication, and taking medication properly, that may be very challenging to do while addressing multiple issues in your life. So that if we think systemically, everything we do needs to be designed to welcome, engage, and provide integrated services, including psychopharmacology services in an integrated perspective to people with co-occurring issues and other complex needs. So within the framework of thinking about this, we want all of you who are watching to kind of enter into this with a very interesting mindset, which is that every program needs to be thinking of itself as a co-occurring program, because you already have people with co-occurring issues in your doors, and you want to organize yourself to help them as much as you can. Similarly, every person, every practice needs to be able to be designed to be appropriately matched for people with co-occurring issues who are being seen, including psychopharmacologic practice. And we can call this approach a program of recovery for systems, so that all of us move together in a common direction to help the people who need us the most. Is this your vision? And if it is, how would you get there? That's one of the things that this webinar and the other webinars in this series are designed to help you to move in the context of the larger approach that's called recovery to practice. And what we're going to do today is start by digging into detail on the first principle and a little bit of the second principle. Here's the first principle. When you walk in your office to prescribe medicine or to meet anybody who is likely to be seen in the context, particularly of mental health service or substance service, particularly if you're working in a public sector setting, you're going to find that complexity is an expectation. And the principle is that we want to build that expectation in a welcoming manner into absolutely everything we do, and remove access barriers that make it hard for people to be welcomed, even though they may seem to have been established since the beginning of time. And welcome the opportunity not only to welcome the person as they are, but to make it easy for them to share all of their issues inside their work with us. Now, in this webinar series, all of you have had a chance to review the story of Nick M., who is a man who is coming in for an evaluation, a psychopharmacologic assessment with concerns about both alcohol dependence, or alcohol addiction, and major depression. And what you want to be saying to him is welcome. Nick, or Mr. M, you are in the right place. I am very glad you're here. I know that you have a lot of challenges in your life. You've had a lot of ups and downs. It must have been very difficult for you to have made the decision to come to see me. And I want to let you know that I'm very, very glad you're here. You're a person who has lots of things going on, and you're exactly the kind of person that I personally enjoy helping. And my goal in meeting you is not to try to fit you into some box, but I want to get to know you. I want to inspire you with hope. I want to help work with you and any other members of our treatment team that we can find to help you with all of your issues, your mental health issues, your substance issues, but your life as a whole. So we can work together to help you make progress over time to achieve a happy, hopeful, beautiful, and successful life. Now, there's nothing in that speech that's rocket science. The thing that I'm saying to you always is to be thinking about how you practice your own speeches so that you can say them not just reading them off an index card or a piece of paper, but looking people in the eye, speaking from the heart, and expressing the care and concern that you already have in a way that helps that person who's probably scared to death to feel like they've made a good choice coming in. And the final thing I want to say is, what are we welcoming people into? We're not just welcoming people in the first moment, but we're welcoming people into an ongoing relationship within which we do the assessment and we do ongoing intervention over time. And this relationship has to be conceived of as a partnership. This is what we've learned is what helps people. The partnership includes things like shared decision-making, which we'll be talking about in other webinars. It's a partnership that's empathic and hopeful. It's integrated, and it's built on strength. And it works with people in small steps over time to help them with all their issues, because the best practice care for people with co-occurring issues takes time to help people move in small steps to achieve their goals. So I'm going to transition now to Dr. Chris Gordon, who's going to dig further into some of the strategies as a psychiatrist that he uses to welcome and engage people who have complex and co-occurring needs.
Thanks very much, Ken. That was a superb introduction. And as you mentioned, I just want to offer a few ideas from my actual practice about how we can make engagement warm and welcoming and hopefully very effective. And we can begin with sort of a commonplace idea that, of course, good outcomes, especially for people who are facing complex challenges, are a whole lot more likely if that person experiences a durable, solid, good, and warm relationship with his or her healthcare provider. And that those relationships are an awful lot more likely to occur if we get off on the right foot and that the process of engagement goes well. And probably the most important ingredient in that kind of engagement, from my point of view, is time. Working at a pace where there's enough space and time to get to know the person as a person and not just as a problem list. And for those of us who actually work in clinics, we can appreciate that this is an enormously challenging problem because time is in terribly short supply. But this kind of unhurried welcome is what's necessary for us to lead with the person's strengths and for us to be able to meet the person with an open mind and an open heart. And as Ken also was emphasizing, the tone of what we do and say is probably at least as important as the substance of what we do and say. That is that a tone of friendliness, warmth, optimism, and what I like to think of as neighborliness are really very, very important. For us physicians, it's really important, I believe, as we look over the person's history, to pay as much attention to spot and highlight the person's strengths, accomplishments, and just good qualities as we do to their symptoms, problems, and possible diagnoses. Mr. M's history is filled with such strengths and accomplishments. He emigrated to this country when he was 18. He's achieved full citizenship. He's a bilingual person. He's a devoted father. He's a person of deep religious faith, and he's a member of a faith community. All of these are very important attributes. And for us physicians, it's particularly important for us to beware of clinical histories or symptom lists that would tend to push us in a particular predetermined direction about treatment before we took the time to get to know what Mr. M's perspective is himself on what his problems are and are not and what the best approach would be toward their management. It's really important also for us to take stock and to notice the adaptive coping side of whatever the person has been doing to deal with their difficulties. One thing that leaps out from Mr. M's history, for example, is that he's been trying so hard to find work to provide for his children that he prioritized that over his own care. That's a different way of looking at what happened than that he just didn't do the work to come to treatment in the past. It's also very important to include an inventory of the person's culture and other aspects of their identity, their faith system, their racial, gender, and sexual identification, their country of origin, or any other group with which they identify can be really important clues towards strengths, resources, and open ideas for pathways to recovery. It's also really important, particularly for those of us who are physicians, to take note of the power asymmetry that exists between us and the people who come to us for care. And we really need to take note of this in order to make room for collaboration and mutuality. This is even more important for people who have had lousy, painful experiences with the mental health system in the past. And unfortunately, that describes an awful lot of people. So we're not starting from neutral. As Ken said, very often people approach us with great wariness, great fear. And we have to do things actively to reassure them that we're not going to be harmful to them. So one thing that seems to be helpful in my own practice, which I would like to share with you, is that I often, early on in the conversation, offer to share what I know or think I know and invite correction right off the bat. This permits me to show my cards first, to show that I'm open to correction and input, and it also gives me an opportunity to share the information that I have in a strength-based and non-pathologizing way. So for example, I could ask Mr. M if he would like me to share the information that came to me from the hospital. And I could say, I could share with you what's written on this paper, and that way if any of this information is wrong, you could straighten me out right away. By the way, it almost invariably is wrong, so that gives the person to make a contribution right at the beginning of the conversation. But if it were okay with Mr. M, I could then go on to say, I see here that you came to the U.S. when you were only 18, that you've accomplished the task of becoming a citizen, which is awesome. I see that you're a dad, that you have a daughter and a son, that you've been working really hard to provide for them and to see them. But I also see here that things have been very hard recently, and that your family, your marriage has recently ended, and that it's been very, very hard for you to find work to provide for your kids. And I can imagine this may have been very discouraging, and maybe that contributed to the difficulties with the depression and with the drinking. It's our hope, of course, that presenting this information in this, what I hope is coming across as a friendly, warm, and strength-based way, makes a space for mutual conversation and collaboration, and lets us move smoothly then into looking back over what has helped and what hasn't. So I could ask, just in plain speech, Mr. M, as you look back over the last couple of years, do things jump out at you that have been particularly helpful that we could build on? Or have there been things that have been really awful that we would want to avoid? And that can lead to a discussion about the person's perspectives on what would be best to do and not to do. So I could share with him, for example, I see that you've had really bad experiences with antidepressants. Was your experience so bad that your mind would be just closed to antidepressants in the future? Or would your mind be open to exploring some other options? That way of acknowledging right off the get-go that resistance to antidepressants is completely understandable when you've had terrible side effects is a good way of beginning a more open conversation. It would also enable me to begin to ask questions about how much of a problem does Mr. M really see his drinking as being. It can be a terrible mistake for me to make assumptions that he identifies this as a bigger problem than he himself does. And that disconnection can lead to really poor misalliance. It also can help me open up some discussion about what his hopes and dreams are for the next couple of weeks, the next couple of months, the next couple of years. As Ken said, good engagement also really flourishes when we have good things to offer people. And often this is best when these options are culturally familiar and comfortable to the person. So in Mr. M's case, resources that are connected to the Brazilian American community or that are connected with his Catholic faith might be much more congenial to him than resources that are not. And of course, peer specialists, people who have been there, done that, who can speak with an authority greater than any of us professionals, are a great way of legitimizing the options we have to offer. I think I'd like to now turn to my colleague Jackie Pettis, who can really do a much deeper dive into the issues of cultural competence. So Jackie, I'll turn this over to you now.
Thank you. Okay, one of the things I want to say in terms of listening to what Dr. Minkoff and Dr. Gordon have already said, just in listening to what you said, I feel very welcomed and I would be easily to be engaged in your practice. And I think some of what I'm going to talk about as it relates to culture has been mentioned before, and it just kind of pulls it all together so that there's a connectedness here. And so this definition here of culture, we know that there are many definitions and that culture is very layered and complex. But this particular definition on the integrated pattern of human behavior that includes language, thoughts, communications, actions, customs, beliefs, etc., comes from the Federal Office of Minority Health. So this is just one of many that I'm sure that you have all seen. Culture is very personal And it's an important aspect of patient care to understand, because it is an essential component of person-centered care and shared decision-making. And I think that, as we've heard throughout this presentation, it's very important to see the person as an individual and recognize that there are many components of culture, and that it's important to see that person that is sitting in front of you, what they present and how they identify themselves. And of course, people can identify with more than one culture. Looking at our case study, we know that when it comes to culture, personal and cultural beliefs are going to influence how the client, his perception of his illness, as well as the healing process. And so we have to understand how a person explains their illness and some of the origins of where these explanations come from, and that will help people engage in treatment and allow the clinician also to speak using terms that a person understands. And all of that helps in developing that relationship that is so important from the very beginning and throughout treatment. And looking at, again, looking at the case study and some of the things that came up that I think were kind of challenges when there's a difference in cultural beliefs between the person seeking treatment and the clinicians. One thing here in our case, Mr. M feels lonely, and even though he lists his church community as an important source of support, with the consent of his ex-wife, that may be a way, she may be a person who can provide an important sense of cultural history and beliefs and information about community resources that they are connected to, or that he is connected to, that can be used to help throughout his plan for improving his life. He is also a first-generation immigrant whose parents and siblings still live in Brazil, and there may be unmet cultural expectations and family obligations that are causing additional stress and contributing to his heavy drinking and depression, because this is a man who values his family and is very much connected to his children, and he's been working, and he's shown that he's very resilient and very intentional about being successful in his life. So it's probably very stressful to him that he may not be able to do some of the things that he values. The good news is that, as you've heard before, the strengths, okay, there we go. In talking about strategies to address some of these things that have already been talked about and that can be seen as challenges, the good news is that Nick has many strengths, and you've heard Dr. Minkoff and Dr. Gordon talk about some of these strengths, that it takes a lot of determination to learn English as a second language, and he came here at a young age and became educated and a naturalized citizen. You know, he's managed, in spite of his challenges, to secure housing, and he has a very strong faith in faith and relationships in his community, as well as relationships with his children that he has seen as a priority. And in spite of his low resources, he's made an effort to spend time with them. Cultural identity, as we mentioned before, is individualized. And because of that, in interacting with Mr. M and with anyone who's coming for treatment, it's important to ask them about their cultural beliefs and their values and experiences, because just because a person is from a certain group, we don't want to see them as that group as monolithic and begin to stereotype people. So I think it begins with what the person thinks individually. And so, as has already been mentioned, you're not really going through a list and putting people into a box. Each person that comes should be looked at individually as a person and what they value. Again, from a strength-based perspective, and we've heard this mentioned also earlier, so again, it's like looking at and asking him what's going well in his life, focusing on what he wants to do, focusing on not just his symptoms, but where does he want to go. And we've seen that he had several hopes and dreams that he's been able to accomplish, and right now he's just a little down on his luck. Because this is very important to direct care instead of going down the list of, for this particular diagnosis perhaps, these are things that are recommended. Those things, that may be true, but also from a personal perspective, this person will have some specific ideas of what will help them get better. And also it's important to find out if there are specific customs and beliefs that he feels are important that can be integrated into his care. Also, he's been in care before. It said that he had been in detox treatment before, so it's important to ask him what, if anything, did he find helpful in the past, and what are his expectations currently of treatment. And then in looking at how they're going to develop goals, the clinician is also going to share their expectations and come to an agreement on where to begin. I think also from a cultural perspective, his faith is a strong component in his life, and so it may be important in asking him to look more at those deeply at those relationships that he has with his church family as a place of support, because they may offer, many faith communities offer like Celebrate Recovery or other 12-step fellowships that are based on a particular person's religious beliefs. And also with his permission, we might want to reach out or have someone reach out to his supporters, because again, he mentioned that they were a primary sense of importance in his life, and yet he still felt somewhat isolated. And lastly, I think that in pulling it all together from a cultural perspective and looking at the complete person, the treatment goals are developed together. That shared decision-making, person-centered planning will focus on what the person identifies as most important and what type of support that person needs. Thank you.
So thank you very much, Jackie and Chris. Those were exceptional presentations, and I just want to, take a minute to summarize some of the things that I got from listening to these presentations that might be takeaways. And the three words that I'm thinking about that struck me are neighborliness, taking time, being a team, and understanding the person and their context. And let's just summarize how important this is, because the most important overriding message of this webinar is that before you dive into focusing on diagnosis and prescribing medication, the most important contributors to success is the degree to which you establish a relationship. No matter how much or how little time you have in the encounter, you need to purposefully plan time to establish that relationship. You're not going to find out a person's entire life story in 10 minutes, but you can make a relationship. It starts with the idea of being neighborly. And finally, understanding people is not understanding just their illness. This is not a depressive and an alcoholic. This is a person who, among many other things, struggles with depression and alcoholism. Understanding his context, his culture, his beliefs, that he has a family, both in Brazil and here, that are very important to him. Being neighborly enough to ask about it, and then to be asking, where does anything I can do to help you fit into what you're trying to do in your life and in relationship to the people you love? Thank you very much.
Thank you for joining us. We will be discussing stage-based interventions, including peer supports for individuals with co-occurring mental health and substance abuse conditions. Your presenters today are Dr. Ken Minkoff. Dr. Minkoff is a senior system consultant at Zia Partners Incorporated and the clinical assistant professor of psychiatry, Harvard Medical School. And myself, Melody Reefer. I am a senior program manager at Advocates for Human Potential. We will be presenting and facilitating the discussion. The learning objectives for this module are, number 1, to detail the application of stages of change and stage-based interventions in recovery-oriented treatment, including psychopharmacology for people with co-occurring mental and substance use disorders. And number 2, to describe the value of peer supporters in working with persons in various stages of change. I will now turn over our module to Dr. Minkoff.
Thank you, Melody. In previous modules in the series, we reviewed the principles of recovery-oriented integrated treatment for individuals with co-occurring mental health substance use conditions, and gave a general overview of how those principles related to the procedures within psychopharmacologic practice in particular, although also could be applied in other settings. And what we're going to be doing in this particular module is going into more detail on what stage of change means, what stage matching means, stage matched interventions and stage matched outcomes, and looking at how to apply different types of stage matched intervention in the situation of Nick M walking into for a psychopharmacologic initial visit. And we're going to use Nick's story, but we're also going to illustrate different possibilities in Nick's story based on what he might say when you ask him questions that are designed to elicit his stage of change for his various issues. In this principle, one of the first things to recognize is that when someone asks you or you think about what stage of change is a person in, the correct answer is for which issue or condition. So that even though people have many issues, it is not uncommon for the people we work with as well as for ourselves that we're in different stages of change for each one. So in general, people may say, I'm interested in working on getting help for my mental health issue, including medication, but I'm not interested in a variety of ways or only partly interested in addressing my substance use. Conversely, people may say, I'm interested in working on sobriety because I think I have a real serious problem with substance use issues, but I don't think I have a mental illness. I may have painful feelings, but I hope that they'll clear up when I get sober. And some people may say, I don't want to work on either of those issues. The only thing I have is a judge problem or a relationship problem or a job problem or a housing problem. And so one of the things we've learned as a best practice is that it's important to meet people in a partnership exactly where they are and not to struggle. And then to identify where they are in their approach to each issue and provide an interaction or an intervention that's matched to where the person is in relationship to his or her most important goals. And then design what we're doing to help them make progress with us through those stages so that the intervention is stage matched and we know that the outcome will be stage matched again as we're moving in small steps. And what we call that is integrated stage matched interventions for each condition. What are some simple ways in a busy psychopharmacologic office practice to begin to think about what stage of change somebody is in? So one of the things that I recommend is using these simple sentence prompts for each issue. And to ask yourself the question, in relationship to this person's goals and in relationship to me, what sentence best approximates their current position on this issue? So, and then there are 6 stages of change that we can use. And those are just approximations. It's a way of helping you guide your thinking so that you can be more effectively matched to the individual for each issue. And of course, the challenge for us, particularly those of us who prescribe medication, is that we're doers. So we tend to always be in the action phase. And we get frustrated when the people we're working with are not in the same place that we are. And so this is a way of thinking, is a piece of discipline that allows you to calm down and feel that it's really legitimate to be with the person and that helping them make progress through the stages is actually a measure of success. So here's the first one, pre-contemplation. You may think this is an issue, but I don't. And even if I do, I don't want to deal with it. So don't bug me. So in Nick's case, this may be in either direction. He may come in and say, Doc, I really, really want help with my depression. I've heard that antidepressants are great, That's the thing I need. And until I'm, you know, and I know they say I have a substance problem, but I don't. And don't really be talking to me about drinking. That's none of your business. It's not an issue. I just want help for my depression. Now, in this scenario, Nick is not saying that, but he could. And conversely, he could come at it the other way. You know, I want help with my sobriety. I've heard that there are medications that can help me with sobriety. They're saying I'm crazy. I have some kind of mental illness. I don't really think I do, and I don't want to see a psychiatrist for mental illness because in my culture, being crazy is very, very bad. But it's okay for me to have a drinking problem. The next stage is contemplation. Okay? I'm willing to talk with you about this issue, think about whether I want to change, but I have no interest in changing, at least not right now. So contemplation is about talking and thinking and considering. And one of the things to keep in mind in the concept of stage matching is that if people are in pre-contemplation when you meet them, your job is to use basically what we call motivational interviewing or motivational enhancement strategies. And the outcome you're looking for is not to help get people from pre-contemplation to action or maintenance, is to have them go from pre-contemplation to contemplation. So if somebody says, don't bug me, your job is to say, look, I'm not here to bug you. I'm here to be a great partner and help you figure out the right decisions for all of your issues with me, with the team, so that we can make progress toward your goals. And I want you to figure out the right amount of drinking for you in order to achieve your goals. I want to help you figure out the right way for you to deal with your depressed moods in order for you to achieve your goals. And if you and I can just talk together and think together, then we can figure out what's going to be right for you. And if the person is able to go with you into that area, then you have successfully helped them to move from pre-contemplation to contemplation. The more that you push on people, the more likely they are to go the wrong way. Once people are in contemplation, you're talking and thinking with them. And your goal, again, is not to move from contemplation to perfection. Your goal is to move from contemplation to preparation. And preparation looks like not, I'm ready to start changing, but I haven't started. I need some help to know how to begin. Preparation sometimes means, okay, I now understand I have a major mental health condition called major depression, and I want to make a full lifelong commitment to being on antidepressants for the rest of my life. But on the other hand, it's not as likely to mean that. What it's more likely to mean is, you know, maybe antidepressants might help me. Maybe there's some aspect of my depression that's more than my situation. Maybe I'm willing to give it a try, knowing that it's got all kinds of challenges attached to it. Side effects, doesn't work well, you know, perfectly right away, takes time. And I still need to deal with my life, but maybe this would be a helpful tool. Or similarly, I might, you know, I've always heard that I can get sober just by going to AA meetings, but I never heard about medication-assisted treatment before. Maybe I'm willing to give it a try. And preparation might mean, well, you know, where you say, well, look, let's go small. Let's try it for a week and see how it goes. You're not making any more commitment than that. You know, and we'll see if it feels comfortable, if we have to adjust, if you have any unpleasant side effects. We're working as partners here to see how things work. From preparation, people might move into early action. I've begun to make some changes and need some help to continue, but I'm not committed to maintenance as you would define it or to following all of your recommendations. Now, when you're as a prescriber, we often get upset when people aren't committed to following all of our recommendations. And a long time ago, when I was what I say sometimes is when I was a junior baby newbie doctor, I used to think the reason people wouldn't follow my recommendations is because I wasn't saying them properly. But now that I have a lot more experience, I realize that, you know, and I'm an official national expert on co-occurring disorders, which is why I get to do this webinar. People pay a lot of money to hear my opinions, and they still don't follow. It's just the way it is. So when you're working with people and they start to make change, remember that this is a shared decision-making process at every step. And people are going to explore all of our recommendations and decide whether or not they're right for them. And truthfully, we may have some great ideas, but we don't necessarily know what's best for people. Our job is to join with them and help them to figure it out. So when people are in the early action phase, as Nick might be, in the sense that he's just getting started, coming for help. And if we try too hard to sell him on something too perfect too soon, he's probably not going to want to come back and work with us. So, we're going to be working with him in an exploration to say, well, try antidepressants maybe for a while and see how they work. See if they're a helpful tool for you along with all the other things you're doing to try to help your mood. Maybe medication-assisted treatment would be a great tool. But if you're not interested in it right now, that's fine. Let's do some other things to see how your sobriety goes, knowing that we have some tools that could help you if you begin along the way to feel like you're having some struggle. And as a prescriber, I'm sitting here as your partner, ready to work with you as we go. As people move along with us, they are likely to get more toward a late action phase, where the people, somebody like Nick might say, look, in order for me to achieve my goals, and his goals have to do with, getting a job that he feels proud of, being a great dad to his kids, being connected with other people that he can relate to, feeling proud and successful as a man, as well as a parent. And he may say, as difficult as it may be for me in a variety of ways, starting to take care of myself and getting the help that I need to address these issues that I have, which are not my fault, but get in my way, is going to help me toward my goals. And I really need to work pretty hard at this. I need to do everything I can to get to the point that I can manage these things for myself successfully. And at that point, he may be saying, I'm working toward maintenance, but I haven't gotten there. I need some help to get there. And what's important to realize is once people decide they want to do everything they can, they generally don't know how to do everything they can. It's not simply us telling them what to do. It's us partnering with them to help them to learn. So if Nick were to say, I want to make a commitment now to taking antidepressants and doing everything I can, therapy, he wouldn't use these words, cognitive behavioral treatment to manage my depression as well as trying to get my life in order, he wouldn't know how to do all of those things. And so our job is to say, hey, as you're working with antidepressants, realize that, an important part of success for anybody taking an antidepressant medication is working closely with your prescriber and with your team, talking about effects, side effects, as openly as possible. Because we know that it's unusual that the first thing we try works perfectly. People almost always need constant adjustment, need help thinking about how to take it, when to take it, may have questions about potential effects, side effects. What should I do with the medication if I should slip and start drinking? Should I keep taking it? And which for Nick, the recommendation would be yes. But we would also advise him to have the skills to call us at any time if he had any question about what had happened and what was safe. So all of this is a way of helping people in this stage work towards a partnership. And the same conversation could happen if we were talking to him about being in late action for his medication-assisted treatment. And then finally, once people are stable, the conversation is, how do I help you stay that way? And, it's not inappropriate at all. It's when people are stable. One of the questions that they ask is, how do I know I need to keep taking my medication? And engaging in that partnership with people is very important. And for some people, let's say for somebody like Nick, who's never really had a substantially successful trial of medication, the question of whether he needs to stay on it is an open question. You know, if he achieves a full remission of his depression, he's had several prior episodes, you could say, so the risk of having a recurrence is high if he goes off medication, but it's not guaranteed, particularly if other things in his life have shifted. The thing that's important is helping him realize that that the risk is his, and that if he's going to take that risk, you want to work with him as closely as possible, so that if things start to go awry, he and you together can catch it as soon as possible and reinstitute medication if that's what he wants, in order to help him not go all the way backwards. And the same thing if he's working with medication for his addiction. Now, one of the things that's very important to realize is that as I'm going through this, I'm talking about stage-matched interventions for each issue within the stage. But it's highly likely that when you meet an actual Nick, that he will be in one stage of change, different stages of change for different things. And as you're working in partnership with him, the art of doing this is to identify the things that are most important to him, which are probably not going to be either mental illness or alcohol use disorder. They're going to be things to do with his actual life, getting a job, being a parent, and so on. And then with those things that are most important, making that partnership, how are we working holistically or in totality to help you towards your goal? And then where is it that we can meet you where you're at about how to best address your depression or how to best address your substance use? And then assuming that he may be in different places around his mental illness and addiction, you work with the one he most wants to work with and engage him as best you can in conversation and finding small steps toward the other. So I'm going to turn it back to Melody, who's going to talk about how helpful and important it is to engage people who provide peer support in this stage-matched intervention process.
Thank you, Dr. Minkoff. I want to step back for just a moment to review for our audience some definitions, and specifically looking at definition for recovery, and I'm including in that the framework of resiliency, because it's such a critical component to serve as a backdrop for all of the stages of change. SAMHSA has done some incredible work around developing consensus for these definitions, and the information I'm sharing is available on the SAMHSA website. Their approach for defining recovery begins first with defining 4 dimensions of personhood that are relevant for recovery, those being overall health, stable home, purpose in one's life, and membership in one's community. These 4 dimensions of overall personhood are part of what drives identifying the goal that would motivate someone like Nick in identifying the stage of change that he is experiencing, and become foundational. So health looks at overcoming or managing one's diseases or symptoms, if you will. So that could be inclusive of learning to abstain from alcohol or illicit drugs or non-prescribed medications. And it could include managing one's physical illnesses such as diabetes, heart disease, respiratory illnesses, that addressing one's health becomes a key priority. Having a roof over your head, a safe, stable place to live in the community of your choosing is also critical for recovery. Having meaningful daily activities, which for some people automatically means work, employment, but for other people will mean being a stay-at-home parent, volunteerism, or attending school. Even activities that look more like being an artist, being creative. But if the activity is what creates meaning and purpose in your life, then it becomes vital to your recovery. And then finally, feeling membership or relationship with your community. And this might be in very broad terms, for instance, through social networks, or it might be in much more intimate terms, relationships with family, friendships, membership in one's faith and spiritual practice. But those four dimensions make up and contribute to overall wellness, recovery, and resiliency. The definition for recovery at SAMHSA's website also identifies some core principles that I won't outline for you now, but I hope you've had a chance to review as you've looked at this slide. And again, please note that that information is available to you on the SAMHSA website. Now, in relationship to how peer support and the employment of those people with the lived experience of recovery can interact with stages of change, I think there are some important elements to consider. Hiring people as peer specialists or recovery coaches brings in strengths-based services that benefit from having the authentic voice of the peer perspective integrated at all levels of care. And that peer specialist or recovery coach can be the prescriber's best ally in helping identify the stage of change the person is experiencing and the indicators of what the bridges to increasing stages of change may be. Seeing that recovery is real is the most effective way of conveying that reality. So my existence as a person in recovery, I'm strengthened by looking at my colleagues who are also in recovery, and people who are entering services can hopefully look at my life and see that regardless of what the barriers were or what the obstacles were, it's possible to overcome those and have a life worth living. Having those insights achieved through the lived experience aids both the person being served and the team members who may not have experienced recovery firsthand. Again, it brings an authenticity and a truth to what's being said about the for recovery. Peer support in and of itself is often naturally occurring. If you've spent any time in a support group or a 12-step group or a group therapy setting in inpatient or outpatient programs, you see that the relationships between the members are what bring the most defining and sometimes awesome moments of clarity and insight. Group facilitators, of course, try to nurture those exchanges. But what people experience while they're hanging out outside the door or making contact in between meetings, that is peer support. The value of peer support as a more formal process through which people receive additional training and when they operate from a code of ethics is bridging that natural support with the professional disciplines that participate in providing services and support to those people seeking recovery. The skill set, however, for the person functioning as a peer supporter or as a recovery coach draws most distinctly from their lived experience of recovery as the unique expertise. So a prescriber goes through numbers of years of learning and education to become experts in medication. experts in dosing, experts in evaluation and assessment. Peer supporters and recovery coaches go through years of experiencing illness, displacement, the cost of having a diagnosis, and then working through that with various supporters and changes in their life to be able to then offer their recovery lessons as a gift to others. So the peer supporters will sometimes be able to offer a unique insight that can help establish the appropriate assessment of the stage of change a person may be, or when those stages are at conflict with each other. So I might be highly motivated to manage my diabetes, but less motivated to manage my drinking. And it might be a peer provider who learns of this tension and can help bring the conversation to a more conscious level of communication. Thank you for joining us today. We will be looking at recovery and support strategies for individuals with co-occurring mental health and substance use conditions. Our presenters are Dr. Minkoff. Dr. Minkoff is the Senior System Consultant at Zia Partners Incorporated and a Clinical Assistant Professor of Psychiatry at Harvard Medical School. Dr. Wayne Centrone, who is the Senior Health Advisor at the Center for Social Innovation and the Executive Director of Health Bridges International. My name is Melody Reefer, and I'm a Senior Program Manager at Advocates for Human Potential. We will be facilitating this discussion. The learning objectives for this module include to demonstrate how to develop a recovery support plan including natural support networks, and to identify 3 potential interventions to support a sample client's recovery that can be used in psychopharmacologic practice settings. Dr. Minkoff, would you start us off today?
Thank you, Melody. So in this module in our series, our focus is on helping the individual to get into the specifics of developing a recovery support plan, a plan that the person that usually has 2 components, things that the person does by him or herself to address various issues going forward, and things that the person will be doing in relationship to his or her support system. When we start working with people on really solidifying a recovery support plan, we're usually working with people at that point to develop a recovery support plan around the issue or issues for which they are in the later stages of change. So in this particular slide, we show not all of the stages, but the last 2, which are called late action and maintenance. So in a certain sense, and this certainly applies to Nick, he may say in relationship to his substance use, well, I'm working towards sobriety. This is something that's important, but clearly I haven't gotten there, and I need some help to get there. And for Nick, in this instance, a recovery support plan would incorporate the details of how to help him to get there. Same thing may apply to depression. Or someone, not Nick in this instance, but it may be Nick a few months from now, may say, well, I've achieved some stability, but I'm worried that I'm going to go backwards. So, for example, he may say, I've achieved some sobriety. I've been sober for several months. Now I have a job. But at my job, everybody is using drugs and drinking. And I'm worried that, and I have some more money in my pocket. And I'm worried that it's going to be easy for me to go backwards. And so I need a recovery support plan that helps me to stay where I am. And again, the same thing may apply. He may be saying, oh, I've been taking these antidepressants. I don't really like them. I think they may have helped me. But I'm thinking maybe now that I have a job, I don't need medication anymore. But I am worried that I might go backwards. I don't want to go backwards. What should I do to keep myself on track? So in this next principle, we talk about the things that a way of framing what we're doing so it's focused on helping people stay on track. And the emphasis here is that the process of developing a recovery support plan involves not only adding in content and knowledge, recommendations, education, and support, but it involves helping people develop the skills they need to do what is going to be helpful. And we call that skill-based learning, and we put it in a context of adequately supported, adequately rewarded skill-based learning for each condition. So the first thing about this is the intention to shift our emphasis from what we know, say, teach, recommend, to our ability to work as a partner with an individual to help that person to learn. Now, the next piece of this is that the steps are small and practical. The way that any of us learn is not just by reading or talking or attending to a course. We have to learn by doing. And it's important to break those steps down into smaller and smaller steps so that people can learn and be successful in actually practicing and making change. Practice, rehearsal, repetition are critical elements of adult learning. Now within this, there are two kinds of skills. There are self-management skills, and there are asking for help skills. So in the self-management skills, one of the things that we're looking at are what are the things that I do when I'm by myself to help myself with getting through periods where my symptoms may be exacerbated. So Nick, even with antidepressants, if you choose to take them, you're going to have times when you feel very depressed. Sometimes because things in your life have not gone well, sometimes because medication rarely works perfectly right off the bat. How are you going to get through those times in a way that is successful for you and without feeling like you need to pick up a drink? And as a physician, one of the things you might be doing with Nick is to help him develop some very practical skills in a very short period of time. It might help you to keep a mood chart and just track how you're doing and write down some of the things you're trying so that you can develop a repertoire of things that work. Or Nick, let's make a list of 10 or 15 things that you can do, even if they only last a few minutes, to help you to address depression. And let's have that list available to you to help you get through the periods of time that are difficult. Now, when this is more elaborated, people develop what we call wellness recovery action plans or similar kinds of plans, not following that particular approach, so that they actually have that structure for it. The same thing if you're in a position where you're suddenly craving a drink and you're all by yourself, what do you do to get through that period so that it settles down and you can regroup? Now the next set of skills are asking for help skills. In the language of AA, people often say it's a simple program, don't drink, go to meetings, ask for help. Well, actually none of those things is that simple. It's hard to know how to not drink or drug when all the people around you may be using, including all of your close relatives, and you're a nice person and you don't like to upset people by saying no. And so you have to learn how to do that. And you do it in small steps by practice. Going to meetings, what do you do there? What do you say there? Are you required to tell everybody what medication you're on? And the answer is no. You're not going to meetings to get medication advice. You're going to get support and make connections with people who are trying to help you not drink or not use drugs. And asking for help when you're in trouble. What does it mean? I need a job. I need a loan. No, it means I'm having a hard time. I need to reach out to somebody in that moment. And most people learn how to say ask for help if you ask them what are you going to do when you're in trouble. But if you then follow, it doesn't mean they know how to do it. So it's very important to help people practice the skill of asking for help. So one of the things that I frequently do is to say, look, if you're having a hard time, what are you going to do? And they're going to say, I'm going to ask for help. You know, you feel like drinking. What are you going to do? I'm going to ask for help. Who are you going to call? Who are you going to ask? Well, this is important because if you're having a hard time, even over the next few days, it would be nice for you to know that you could call someone. Who would you call? And he says, I don't know. I don't think I should call my ex-wife. And I say, probably not. He said, well, can you call the office and leave a message? Can we practice how you would do that? Here's a crisis line that you can call. Can we practice, rehearse, role play right here, right now, how you would call them up and say, hey, I'm having a hard time. I need to talk to someone for a few minutes so I can get through the hard time and not pick up a drink or not do something to hurt myself. And that is practicing skill development in small steps. And if Nick does that, and then I may ask him to practice it when he gets home. Look, when you get home, call the office right away. Just leave a message on the machine that shows me that you're practicing asking for help. And what do you get? You get a round of applause. Positive reward for small steps of progress. Very basic. Just like when people go to an AA meeting, they get a round of applause from a room full of people for being sober one day. And we need to remember in our partnership with the people that we're helping that learning these skills takes a lifetime. The people are never done. None of us is ever done. We're always working to improve. And it's easy to lay out all the things the world thinks we should do. It's hard to actually practice how to do them and actually start making change. And it's helpful to have teammates who give you big rounds of encouragement every time you make the next small and most difficult step. And it's our job as physicians and everyone else on the team to be in the round of applause business to help that learning to take place. So now I'm going to turn it over to Dr. Centrone and Melody.
Thank you, Dr. Minkoff. Recovery as a process, recovery as a model for working with patients with substance use disorder and mental health conditions is a powerful tool, but it's not the only tool. So how do we use recovery and the recovery philosophy to further understand the extension of our evidence-based practices, the core skills of efficacious, evidence-driven medical service delivery? Well, I think it's important just to understand that recovery is about working with people. William Anthony, a major supporter of the recovery model, describes recovery as a deeply personal, unique process of changing one's attitudes, values, feelings, goals, skills, and/or roles. It is a way of living a satisfying, hopeful, and contributing life, even with limitations caused by illness or diagnosis or conditions. It's about engagement. And so how do we engage Nick, the complexity of Nick, the totality of Nick, in a way that offers recovery, supports recovery, and aligns with his needs in his life? Well, the first is to recognize that Nick has strengths. Nick as a gestalt, as the total person, has many different aspects to his life, some of which are related to the reason he's there to see us on that day, the reason that he came into our clinic in the first place, but many of which are more complex than even just the simple world of diagnosis. They involve culture and social circumstance, the desire for a station in life, a place in life. And so we have to understand Nick from the totality, recognizing that Nick is an immigrant coming to this country seeking hope. At 18 years old, he tells you he came looking for more education. Recognizing that Nick is a father who is deeply in love with his children and wishes to support his family. Recognizing that Nick is a member of a bigger social support network, his church, and the community that he derives from his church. Recognizing that Nick has a strong interest in personal advocacy and describes to you his desire to find gainful employment, to find a job that gives him meaning. recognizing that Nick has already demonstrated self-advocacy in seeking treatment. Nick has told you that he's previously been on psychotropic medication, taken antidepressants, although he stopped taking those because of the side effects. Can we draw from that? Can we learn from that? Can we work with Nick to find a new way to engage medication management to help him find the life that he deserves and so desires? And then how do we work with Nick from the perspective of a demonstration of these strengths? One of the key demonstrations of that is the fact that he's in our office today. He has carried through on the follow-up that was required when he left the hospital. He made the referral. He took the steps to come into our office. How do we draw on that? Well, I think critical is understanding that to some respects Maslow was right. There is a hierarchy of need. Although it doesn't necessarily occur in such a hierarchical way, we do have a foundation, and that foundation is very critical to our life support. I come from a background of working in homeless health service organizations. My core view of the world is through serving people who are experiencing homelessness. And what I found in working with people experiencing homelessness is that seeking to understand the totality of their need means that I have to ask questions about housing and housing stability as though it's a vital sign. That housing has a foundation, right? Maslow said, if we don't have a firm foundation, it's really hard to build anything from. That housing is critical, and that the support that comes from a foundation of housing is critical to finding success in our lives and gaining stability in our lives. So one of the first questions we might want to ask Nick about is, how's your housing situation? Where are you currently living? And what we would learn in asking the question to Nick is that he's living in a single-room occupancy hotel. Stable housing environment as per his definition. But what Nick would then tell us is, I kind of want more. I want a place that I can invite my children to come back to. I want a place that I can actually build a home. Not just have a house, but build a home. So how do we work with that? How do we call forward the recovery opportunities? Well, I think the philosophical precepts to do that are recognizing that trauma is pervasive in people's lives. That Nick has been through trauma, early hospitalizations, early experiences with substance use in his country of origin, the process of moving from your country of origin and repatriating into a life very different. It can be traumatizing. Can we understand that trauma and the totality of that trauma to really work in a recovery-oriented way? Calling forward the strengths that Nick has demonstrated, coming into our office, by demonstrating a commitment to find the tools, the resources to establish wellness in his life, by really focusing on the continuum of recovery and not the event of recovery, that it's a process and it happens over a long period of time for many people and it has ups and downs. And then really supporting him to make decisions that are his best interest. And one of the things that I learned that was critical to the work that I did is that people are people, and they have the right to make their own decisions. And in many circumstances, their decisions at the time are the best decisions for their needs. So how do we support them to move into a place where they can make decisions that move to a better place of recovery, that uses a decision built into a continuum that really seeks and sources wellness? So with Nick, focusing on the person, Barbara Starfield wrote eloquently about this concept of person-focused care and not patient-centered care. And Starfield would say that person-focused care is based on the accumulated knowledge of people, which provides for the basis of better recognition of health problems and needs over time. That the person that we see in the clinical encounter at that visit is more than just the clinical encounter in the visit. That they're a person that has a long continuum, and that our goal should be to contextualize the visit to the content of their lives. That we can work on really person-centered, focused into everything that we do. Berwick, in his classic way of taking complexity and making it tangible, wrote in a 2009 article that we need to understand that there are some seminal maxims of person-focused, recovery-oriented systems of care, and that those are the needs of the patient come first. We must really seek to understand their needs and call forward those needs. Recognizing that recovery has a number of different guiding principles, which are defined as health, home, purpose, and community. And then ultimately recognizing sometimes just normalizing fears and anxieties and frustrations and then calling forward joys are one way that we can individualize care. The data tells us that stable housing is the key to finding wellness in one's life. That you can't, working with someone who has complex social challenges in their life, you can't really create an opportunity for embedded change without addressing solid social support needs. But also that the solid support needs are a platform to really seek better care delivery. So we have to work in understanding that the foundation is critical and that recovery support and strategies occur on a continuum. William White wrote that there should be no wrong door to care, that in a purely recovery-oriented system, every door should be an access to care. And I think that's critical, recognizing that we can draw from a variety of different literatures and understanding the recovery process, that there is a rich level of literature in the adolescent world about resiliency and about strength-based approaches to really engagement and assessment, and that we can work with people by inviting them into collaboration, that we can offer opportunities to help them have new levels of knowledge and insight that prepare them to be partners in sharing decision-making. It's people's lives, and we can provide them with the information. We can do the due diligence of helping them to understand the risks, the benefits, the alternatives, and the opportunities. But ultimately, treatment is their decision. I'm going to turn it over to my colleague, Ms. Reefer, right now, and thank you very much for this opportunity to speak with you.
Thank you very much. One of the things that's really important to me when I think about recovery and supports is that this is not a one-off option or a side dish to services, but rather recovery and supports is a light that should illuminate all services that are being provided. And one way to ensure that recovery and adequate support is being provided to people who are entering into the services that we offer is to integrate peer support workers. This is a way to ensure that peer support becomes a part of the care team and that the peer worker is an equal member on the care team. That peer support helps us move beyond the walls of the facility, whether it be an inpatient or outpatient program, that people actually live their lives outside of our offices. And it's important that the support be available for people where they are physically located as well as where they are emotionally. And an importance of making room and always remembering the power of informal peer support as people work to extend their lives in their communities. So to look at each of these points just a little bit more deeply, peer support is a part of the care team. One of the emerging practices that is happening in our field currently is placing peer workers within the medication clinic and having peer specialists or recovery coaches be a part of the medical team. And so while there might be a nurse and a prescriber that and sometimes even a case manager that's embedded in the medical team, that the introduction of a peer worker into that milieu helps to ensure that the principles that have already been spoken to are carried through. It's really difficult for a prescriber or even a nurse to know or have the time to do those elements of the warm handoff or inquiring about the safety and appropriateness of one's housing and home, or to explore options around medications by reviewing medication fact sheets. An example of where this successful integration has happened is with an approach called Common Ground, developed by Dr. Patricia Deegan. I had the opportunity to work with this program and to work with Pat, and what we were able to observe is that by building out an opportunity for people to prepare to participate in their medication consultation with their prescriber, they were much more likely to advocate for what their needs and values are, and that the peers were able to provide support post-appointment by utilizing vetted educational and decision support materials. Essentially, this is an extension of the medication clinic appointment and helps the agency provide an enhanced experience when, in this day and age, the time limitations created by demand really sometimes serve to circumvent our capacity to provide the quality service that we want. Using peer support to move beyond the walls. The goal of recovery is to live life to the fullest, and that looks different for each person. Nick wants to be more of a hands-on father with his children. He wants that exchange and membership in his faith community. He wants to work. And those are values and activities that equal his living to the fullest. I want to have deep and meaningful relationships with my family members. I don't want any psychiatrics to get in the way of my connections to the people that I love and respect. And so every person's going to be motivated and pulled into their recovery based on personal values. Recovery really must be rooted in the person's community and not limited to just those that 50 minutes with a therapist or that 15 or 20-minute medication consultation, but that their recovery is happening as they're walking down the street, as they are preparing for bed, as they are shopping for their groceries that week, that all of those things are what add up to recovery. Peer support can be a natural connection between the formal services at an agency or a provider and to the life in the person's community. Sometimes people need the modeling of what recovery can look like with boots on the ground, or perhaps the person has lost contact with their family, or they've burned bridges with friends and need to go about setting up a new community. And the peer supporter can be invaluable in helping to create those connections, helping people understand that recovery is a 24/7 commitment. And it's not something that you just do at certain times, is important for understanding that that recovery is ongoing, that it is not a linear process, that it is a dance that we dance through the rest of our lives, which really leads to making room for informal peer support. As prescribers, use that position of authority to prescribe activities that someone can do. Activation is probably one of the most key elements to beginning one's recovery. And so having a prescription of, go to a dance this weekend, or get a membership at the Y and swim twice a week. Those prescriptions can lead someone and open doors to recovery as dramatically and as concretely as a prescription for a specific medication. And then, as has been mentioned, and that we can't really focus on enough, is to inquire about the natural strengths and supports that the person does have in their life. Help them see that there are options and that they are already taking important and significant steps towards their wellness and recovery, that they in fact are resilient. Nick is a resilient person. He is surviving against all odds. And the more we focus on resiliency and people's capacity to make it through both literal and figurative storms in their life, the more they're going to be able to embrace and not be afraid of claiming their natural strengths and support. So be it in other people, in how they view themselves through a cultural lens, what they're doing besides medicine or in addition to medicine, and identifying who can be supportive during those storms are really key importance for helping people acknowledge the and see the informal peer support that exists in their lives. We really thank you for participating on this module. To my colleagues, Dr. Minkoff and Dr. Centrone, thank you for the information that you shared. For more information on this topic, please see the supplemental resources attached to this webinar. We invite you to sign up to receive a quarterly newsletter that is issued by the Recovery to Practice team. If you're not receiving this newsletter, just send an email to rtp@ahpnet.com. We'd be happy to provide you with this informative newsletter on a regular basis.